pleasure is for this to be interactive to tell you a bit about our CFAR, the history of the institutions and sort of where we are today, as well as ideally, since we have a number of visitors from other CFARs and external to discuss places we may collaborate or new partnerships potentially between our group and others. So Dave, thank you for the summary. As Dave said, I'm been at Vanderbilt for really since fellowship, with the exception of some time in Zambia. And my real focus has been HIV comorbidities, and in particular, metabolic disease and adipose tissue biology. But one of the phenomenal things about being part of the CFAR is the opportunity to learn about so many different disciplines, and all really the wonderful people working in Middle Tennessee across Vanderbilt, Meharry, Nashville Cares, Tennessee Department of Health, and also now in Memphis, and the chance to really become educated about their work. So the talk today is the Tennessee Center for AIDS Research, Impact Through a Shared Mission. And the goals of this seminar are to give you a history of our Tennessee CFAR going all the way back to its first iteration, but really its current form since 2015, to share our current and planned future activities, and then ideally to develop ideas for new cross-CFAR collaborations and partnerships. So as Dave said, this is our first external seminar, but it is the seminar series was launched back in April. And this will be something that we'll have every Wednesday at 3 p.m. Central, which will be available through Teams, and it will be going forward the Tennessee CFAR seminar series. And this will be a mix of
John, not every Wednesday, one Wednesday a month.
Oh, I meant to. Okay, sorry, every second Wednesday of the month at 3 p.m. And this will be a mix of internal speakers from our group as well as external speakers. And this is our first externally available presentation. We previously had 4 seminars, which some on the call may have seen, covering our 4 partner institutions. And so this will, however, summarize some of the information that was previously included. And the CFAR seminar series is coordinated through our administrative core. The 3 directors of our CFAR are myself, Dr. James Hildreth, and David Haas. And we could not do this work, though, without the tireless efforts of our administrative core staff, which includes Vicki Myers, our program administrator and our core manager, Heather Jones, our program manager, and Zudi Takazawa, our program coordinator. So I want to thank all of them up front for all their efforts to make this a success and to keep our CFAR running. So I'm going to start all the way back at the beginning of the HIV epidemic, or before we even knew what HIV was. And this was the Tennessee Communicable Disease Bulletin from 1981. And Tennessee is a state, particularly Nashville, that has a lot of people who emigrate out to other areas of the country, and also people who transplant in. And so really very early in the epidemic, we began to see a number of individuals with HIV returning, particularly from the coasts of the US, back to the Nashville area. And this was picked up on the radar of the Tennessee Department of Health. And this was a communicable disease bulletin that went out in October of 1981, which encouraged Tennessee physicians to participate in a nationwide survey looking for instances of Kaposi sarcoma and pneumocystis pneumonia, which I think many people on the call will know were some of the initial manifestations of acquired immune deficiency syndrome before that condition even had a name. So this was on the radar of Tennessee, and this was something that came early to our state, and probably earlier than it may have been observed in high numbers as compared with other cities in the Southwest that may not have been as cosmopolitan. And in fact, this was a condition that the first case was actually treated at Vanderbilt. And I think many people will recognize the individual on this slide, and this is Barney Graham, who came to Vanderbilt initially in 1979, had a long and distinguished career here, then went on to become deputy director of the Vaccine Research Center at NIAID, and is now currently at Morehouse School of Medicine in Atlanta. But he did his internship, his residency, two chief residencies, including Nashville General Hospital and Vanderbilt, his ID fellowship, as well as his PhD, all in Nashville. And then in 1982, while he was chief resident at Nashville General Hospital, which is our community hospital located in North Nashville and also part of the Meharry Medical College campus, he treated Tennessee's first person living with HIV. That experience, he built a lot of our HIV-focused both clinical care and research program at Vanderbilt, as well as at Nashville General Hospital. And then, as we all know, he went on to become a world leader in vaccine biology, design development, and testing. And much of his research was also the basis then for the more recent development of COVID mRNA vaccines. So Tennessee and the Southeast really sit at the epicenter of the ongoing HIV epidemic in the United States. The Southeast has the highest regional prevalence and highest regional incidence of the different regions of the country. And Tennessee itself, a number of its urban areas have very high rates. So at the top of the list, both within the Southeast and nationally, is Memphis, which currently ranks number 2 in some surveys, potentially 2, 3, or 4, but very high in HIV incidence among US metropolitan areas. But if you look, you'll also see that our other major population centers here, which include Davidson County, where Nashville is located, as well as Chattanooga and Hamilton County, also have very high incidence rates. But also, if you look at some of the other components of the map, so a few of these counties, which I can't point out specifically with the pointer, but for example, Cannon County, DeKalb County, Jackson County are overwhelmingly rural counties in Tennessee, but they also have very high rates. And so we have both intense urban areas of high HIV prevalence, and then we also have a lot of urban areas. And this has shaped both the care that we deliver, and it's also helped to shape our research agenda. And one thing that's fascinated me and has led to much of the science that I've done, which is if you overlay this county level national HIV prevalence on maps of lack of access to medical care, on maps of county level poverty, on maps of cardiovascular disease, on diabetes incidence, you'll see that many of these same counties with high HIV prevalence overlie with many of these, with counties that also have very high levels of poverty, as well as other non-communicable diseases. So we really have, in many ways, have a multifaceted epidemic here in the Southeast. And that is, as I say, driven some of our comorbidities work, but also some of our social determinants of health and implementation science work as well. So we are the Tennessee CFAR, highlighted there in yellow. We're one of currently 20 Centers for AIDS Research across the United States. And we're one of 4 in what would typically be considered sort of the central southeastern region. That includes Emory University, UAB, UNC, and Duke. We're surrounded then additionally by other CFARs, including University of Miami, which is a bit different environment than the Southeast. And then, of course, the newest addition, and congratulations to the Midwest Developmental CFAR as well. So we are a CFAR, which is actually a 4-way co-equal partnership between several institutions, the first one being Vanderbilt University Medical Center, which is a large research-intensive institution in Nashville. Meharry Medical College, also in Nashville, which is the nation's largest private historically Black academic health sciences center, dedicated to educating healthcare professionals and also conducting medical research. The Tennessee Department of Health, which is an academically engaged state health department with a long history of collaboration with academic institutions in the region, and also Nashville Cares, which is one of the largest and most sophisticated HIV community-based organizations in the Southeast. And I'll tell you more about the history of each of these now. So many people know that Vanderbilt University is named after Cornelius Vanderbilt. He was known as the Commodore based on his work in transatlantic shipping, which is why we are known as the Commodores or the Doors. And he was our school's founding benefactor in 1873. At the time, he was one of the richest Americans in history, but he had actually left school at age 11 to work in the ferry business. And while he was something of a savant and excellent in arithmetic, which aided his career. He actually wasn't as excellent in reading or writing, so we really don't have too many written records from Cornelius himself. But at the urging of his wife, he provided the school with its initial $1 million endowment. And really, the hope with this gift was that the university and the work that it spawned would help to heal the sectional wounds that were inflicted by the American Civil War. So Nashville was never a major battleground in the Civil War, which is one of the reasons why the school was founded here so soon after Reconstruction, as it still had much of the infrastructure that existed. But it was an attempt to heal some of those wounds. And he provided that founding gift at age 79. But unfortunately, he died 4 years later before he had the opportunity to come and see this school that he had founded. And the Vanderbilt School of Medicine was one of the founding schools, one of the founding 4 schools of Vanderbilt University, but it was actually already established prior to Cornelius Vanderbilt's donation. And it was the University of Nashville School of Medicine, which had existed since 1851, which was then absorbed into Vanderbilt. And Vanderbilt is one of the largest regional medical centers in the Southeast, with over 2,500 full-time faculty across our adult, pediatric, and also specialty hospitals. Also a growing multi-state medical group spanning all the way from Texas to, at last check, I think, West Virginia. And Vanderbilt was one of the first schools to really invest in an extensive system of core labs, core labs and other shared resources, which has been one of its great strengths. And additionally, it's one of the a limited number of schools where all of the clinical, academic, and research aspects of the medical center are all consolidated in a single office of leadership, which provides a unified structure of leadership. And it's currently ranked 10th among U.S. medical schools in total NIH support. So about 2 to 3 miles away from Vanderbilt is the other major medical center in Nashville, which is Meharry Medical College, which was founded in 1876 as the medical department of the Central Tennessee College, and now became the modern Meharry Medical College. And it was actually the first medical school in the United States for African Americans located in the South. And it was established, obviously, shortly after the Civil War. And for nearly a century, it was the only place in Middle Tennessee where Black Americans could receive care. And the college has an interesting backstory. It was named for Samuel Meharry, who was a young Irish immigrant, who, according to history or legend, but it's been documented in his own writings, was hauling a load of salt through Kentucky when his wagon slid off the road into a ditch. And it was raining and nightfall was approaching, and he didn't know where to go, so he approached a cabin of a Black family that had recently been freed from slavery. And they brought him in, gave him dinner and a place to stay for the night. And he had no resources at the time, but when he left, he said he was going to do something, to repay this kindness. And he actually later achieved substantial success as a trader. And he and his 4 brothers made a major donation to help establish what is now Meharry Medical College. And Meharry is the nation's largest private, historically Black academic health Sciences Center with a central mission of educating healthcare professionals and biomedical scientists, as well as addressing root causes of health disparities and disparities in health outcomes. And I think it's notable that while it is a leading historically Black medical center, it was not until 1972 that Meharry actually had its first Black president in Dr. Harold West, who you see there on the right. And today, Meharry is another major medical center. It's located, as I said, about 2 to 3 miles away from the Vanderbilt campus in North Nashville. And it surrounds Nashville General Hospital, which is that tall, in the bottom picture, that very tall white building. And it's really a leader in community-oriented healthcare for underserved and minority populations, in training professionals in primary care, medicine, dentistry, allied health services, and graduate studies, and then also in basic clinical and translational research. And the student body of Meharry is comprised approximately 90% of individuals who would be from groups underrepresented in medicine, as well as about 80% of the faculty. And approximately 15% of all Black physicians and about 40% of all Black dentists now practicing in the US actually graduated from Meharry. It's also awarded the lion's share of PhDs received by Black biomedical scientists. And like Vanderbilt, Meharry's research funding has really grown rapidly, but from a percentage basis, even greater, rising from 29 million to over 110 million. So interestingly, despite the fact that we have these two, world-class medical centers separated by only a few miles, and both of them were founded in the 1870s, for a large period of time, they were completely separated. They had limited interactions and interchange for over a century. And it was not until 1999 that the Meharry-Vanderbilt Alliance really formalized the partnership between these two groups. And the goal with formalizing this was, in some ways, it was a response to changes in the healthcare environment and the need to seek partners. But it was also to enhance the educational, scientific, and clinical programs at each of the two institutions and assist with collaborative efforts in the area of medical education as well as the provision of care. And importantly, this partnership provided a foundation, but also a collaborative model, as well as the opportunity for interactions that then led to the launch of the first Vanderbilt Meharry CFAR in 2003. So this is a timeline of the CFARs that Vanderbilt and Meharry have together been engaged. And so the first CFAR was a partnership between only the two institutions, and that started as a developmental CFAR in 2003, and then became a full CFAR in 2005 and ran until 2010. And there was then an unfunded gap when that CFAR ended, and it was 5 years until the next CFAR started. And when the next CFAR was conceptualized, the natural two partners to continue to include were Vanderbilt and Meharry, but also Tennessee Department of Health, which I'd mentioned had longstanding academic relationships within the Nashville area and statewide, was also brought in as a partner. That CFAR then engaged with Nashville Cares from 2015 onward, but it wasn't until 2020 that the partnership was formalized with now a four-partner organization. And as we approach 2025 with the ongoing activities of the CFAR, it remains a four-partner institution. But I'll talk more about our burgeoning work in Memphis and the new individuals and investigators that are joining the CFAR with the recognition that there must be a focus on that area. So the Tennessee CFAR in its current iteration was launched in 2015. At the time, it was led by Simon Malal as the program director. As many of you know, Dr. Malal has been engaged in HIV science for decades and has made many of the seminal discoveries, including everything from thymidine analog toxicity to cells, and particularly the contribution to lipodystrophy, to the molecular and mechanistic basis of abacavir hypersensitivity. And he continues now to just do incredible cutting edge work in HIV immunology and other areas. And he was joined at the time by Dr. James Hildreth, who had recently returned to Meharry as president and CEO, another nationally recognized leading investigator who has been engaged in HIV science, including HIV virology from early in the epidemic, as well as David Haas, who has been at Vanderbilt for much of his career as well, led many of the early clinical trials. And this was the core leadership of the Tennessee CFAR in 2015. I did several other individuals that I'll mention in a moment from TDH as well, but this was the director structure. And as I said, TDH, Tennessee Department of Health, was the third partner in the Tennessee CFAR, and it was a natural addition. TDH is located about 2 miles from Vanderbilt and Meharry, and it has a decades-long history of productive collaboration with Vanderbilt and other academic partners, with those partners providing essentially the analytic heft as well as effort to analyze the extensive data collected by TDH. And prior to the CFAR, this was primarily non-HIV data. But that series of activities helped to establish Tennessee as a leader in the implementation of programs and interventions in various public health fields, and served as a model then for carrying those activities over into the realm of HIV. So TDH collects vast amounts of HIV related data from across the state, and our CFAR, primarily through the Data Science Core, then provides the analytic capacity and expertise. And this has led to a number of highly impactful joint publications, as well as a shuffling of CFAR faculty and staff between both Vanderbilt and TDH to provide some of that analytic expertise. So shown in this picture are three of our key faculty members within the CFAR, which includes Rob Nash, you see there on the left, who previously was a HIV care provider at Vanderbilt. And in fact, when I was a fellow, I learned a great deal from him. He then left Vanderbilt and is now the Deputy Medical Director for HIV Prevention and Treatment at TDH. The individual in the middle is Rand Carpenter, who's Program Director of HIV STIs and viral hepatitis, and then Christine Thomas, who's the Program Medical Director of the same area of HIV, STI, and viral hepatitis. So they're close colleagues within the health department. And then our fourth partner, which I mentioned, joined formally in 2020, is Nashville Cares. As I mentioned, it's one of the largest and most sophisticated community-based organizations within the Southeast, and it's now entering its 39th year of service. CARES serves 17 urban and rural counties around the Middle Tennessee area, which accounts for 90% of the reported HIV prevalence in the middle of our state. They provide case management, behavioral health, transportation assistance, nutritional support, psychosocial service, and other services. They also have a very robust medical clinic known as My House, which provides ART, PrEP, as well as general medical care. They also have these mobile medical units, which you'll see again in the New York Times photo coming up later. But that is the director, Amna Osman, who's a close collaborator within CFAR, there in the photo with one of those mobile medical units. And those have really been critical at reaching some of the difficult to serve populations around Tennessee. So now I wanted to give an overview of our CFAR and talk about some of the developments really over the last 5 years. So we have 4 specific aims to our CFAR. The first aim, I think, is going to be something that's common to most CFARs, which is really to build an infrastructure and build programs to support multidisciplinary HIV research. And this leverages the collaborative local environment, both within each of our institutions as well as between our institutions. And because we are a multi-partner CFAR, we have to place a tremendous emphasis on team science that engages individuals from these different institutions to avoid those becoming individually siloed. The second aim of our CFAR is to nurture and support the career development of early stage investigators. I'll have a slide coming up showing how many of our ESIs have then progressed into leadership within the CFAR. And I think that's a goal of other CFARs as well. But we also see this both important for internal recruitment, but also for growing the number and importantly, the diversity of the next generation of HIV researchers. Our third aim is very specific to expand research opportunities for Meharry investigators. So on a total faculty level, Meharry is, I think, somewhere in the range of 10 to 20% the size of Vanderbilt. So there are fewer individuals there, and just on a sheer size of the campus, it is a smaller campus, and so we want to make sure that that those individuals at Meharry who wish to pursue a high-level career in HIV research have every opportunity that the CFAR can provide. And we do that through collaborations between our partner institutions and ensuring that resources at each of these partners are equally available to everyone. And then finally, And this has really been strengthened by our engagement with CARES, is growing our broad emphasis on HIV-focused, community-engaged research. That is something that we have pursued with passion for many years, and now, because of our growing capacity within implementation science, that's another aspect where we can strengthen our community engagement. So the current structure of our CFAR is probably similar to many others. We have 5 cores. We have the administrative core that myself, Dr. Hildreth, and Dr. Haas lead, and that is where we house our community engagement. We house our strategic advisors, not shown on this slide, our working groups, as well as our interest groups. We have a very active developmental core, which leads much of our ESI mentoring, as well as our pilot programs. We have our clinical sciences core, led by April Pettit, which manages much of our patient-oriented research as well as our recruitment, and now has also moved into the area of CNICs. And additionally, within the clinical sciences core, led by Tim Sterling, is our epidemiology core, what we call Epi Outcomes, that utilizes both data collected from within the CFAR as well as external databases as well. We have a very active laboratory sciences core led by Spiros Callums at Vanderbilt and Bindong Liu at Meharry. And that, again, is one that has been rapidly evolving with changes in available technology. And that's also one where we've been really trying to understand how we can have services at 2 different campuses that really can interact with each other and lead to both exchange of ideas, but also exchange of resources and samples. And then finally, we have our data sciences core, which is led by Stephanie Duda, which is where we house our biostatistics and also much of our bioinformatics support as well. And that is one that has really also been crucial with our internal assessments of success toward our aims, and then also keeping up with productivity of our members and their accomplishments. We have we've had several scientific working groups, and as well as interest groups, and our inter-CFAR group that I'll shown here on this slide. So we have currently an implementation science and HIV scientific working group, which is led by Carolyn Audette, and that we hope will become the implementation science core beginning in May of 2025, and that'll be the most recent addition to our core structure. We have a new health policy and HIV scientific working group that will officially launch in May of 2025, but the planning and membership for that is already underway. We have a longstanding HIV laboratory science interest group that is continuing, and in 2022, our CFAR took over leadership of the Inter-CFAR Faith and Spirituality Research Collaborative. And this is an area I think that's particularly important to us in the Southeast, where we do have many faith leaders as well as churches that are central to essentially community, and also may be in some ways more trusted than, for example, large medical centers. And so this has been a group that we have been very keen to work with and engage and learn from, because we do see it as a key pillar of the response to the HIV epidemic, which is something that really has special place in the southeastern United States. We're going to be leading the national meeting at Meharry, and that'll be, we're going to be hosting the national meeting at Meharry in October of this year, and you can see the link down there to register for that. We have a great lineup of speakers as well as workshops planned. Hotel rooms are available, and if you go to our website, you'll see a page for the Faith and Spirituality Collaborative meeting. So moving on now to our Tennessee core leadership. This is our current leadership, and I'll talk a little bit about some of the recent changes we've had in core leadership in just a moment. But I wanted to show you this so you can get a sense of our current core structure as well as some of the individuals who are leading it. So I think this is probably similar to many CFARs, though I do have the new Implementation Science Core, which is slated to begin in 2015, headed by Carolyn Audette. You'll also see within our administrative core, we have Dr. Kelly Dooley as one of our strategic advisors. She also leads the Vanderbilt Division of Infectious Diseases. And then we have two phenomenal colleagues engaged with advising on community engagement. Latrice Pichon from University of Memphis, as well as Tai Link, who is with CARES as well as the Healthy University program as well. And they have joined our executive committee calls at present, and then they will become formal members of the administrative core beginning in 2015. So as I mentioned, one of the things that we have really emphasized—
Hey, John.
Yes.
You said 2015. I think you meant 2025.
2025. Sorry, Dave. Thank you for that. So one of the things that we have really benefited from in our CFAR, which is something that I know many CFARs have emphasized as well, is essentially the internal development of our ESIs into independent HIV researchers, as well as building leadership capacity and building leadership skills. So this is just a brief example of our homegrown early stage investigators who are now CFAR leaders. And you'll see several individuals who were on the prior slide. So you'll see Dr. Stevie Dash from Meharry, who currently leads our developmental core. And you can see his progression from National Cancer Institute postdoc and fellow to Meharry faculty to his grant awards, and then his work as a co-leader of SWG before becoming the DC Associate Director. April Pettit, a similar progression from fellowship on to faculty, now leads our clinical science core. And you also see Peter Ribeiro, Jessica Castillo, Celestine Wanjala, and Lauren Brown, all of whom now hold associate director or assistant director positions. And we have found that this internal development of leadership to be tremendously effective, both for engaging individuals within the CFAR and then also for leadership within the CFAR. So we're particularly pleased with this progress.
Hey, John.
Yes.
Can I just mention on that slide too, if you go back, just the importance of the developmental core. Everywhere where it says DCA or DCS is where people got a developmental core award or a supplement to help.
Or a supplement, yeah.
Boost their careers.
Yep. Thanks, Dave. That's correct. And we've also, over the past 5 years, undergone a period of tremendous growth as well. So we have added over 20 new faculty engaged with the CFAR since 2020. And these have been individuals that span our partner institutions, as well as individual or from groups that were not previously engaged with our CFAR going back to 2020. So at Meharry, we've had Lauren Brown, who you'll hear more about later, who previously had been at CARES and then joined the Meharry faculty. Daniel Dawes, who is the dean of the new Meharry School of Global Health. Muthu Balasubramaniam, more on the basic science side, and then Christian Amador, who will be co-leading our health policy and HIV scientific working group going forward. On the Vanderbilt side, I won't name everyone, but I would like to point out Tara McKay, who will also be co-leading our health policy and HIV SWG. Kelly Dooley, who was recruited to Vanderbilt as the director of the Division of Infectious Diseases. And also point out that several people on here are from outside the ID field. And so we have new faculty from genetic medicine, from epidemiology, from biostatistics, as well as from gastroenterology, all of whom are engaged in HIV-focused research. Outside of Meharry and Vanderbilt, we have the three new individuals from Tennessee Department of Health, who I mentioned, who are close collaborators. We have Dr. Pichon from the University of Memphis, who, as I said, will be joining the executive committee. We have Qasim Borji from Nashville CARES, who trained at Vanderbilt. He was actually a fellow that we worked together while he was a fellow on his research. He then went to another institution, but was recruited back as the medical director of CARES. We're very excited to have him. And we also have a burgeoning research program within the Vanderbilt School of Nursing as well. Sheila Mulvaney had a Developmental Core Award as well as a supplement, and then Bethany Roten is the recent recipient of a Developmental Core Award as well. So the VS Center Vanderbilt School of Nursing HIV research program is also growing quite quickly. We've seen a tremendous increase in our faculty. We've also seen a tremendous increase in our AIDS-funded research base going back to 2019 as well. So this just shows our FRB going from 2017 onward, but not much of an increase in 2018, and then really bumping up in 2019. And overall, we've had an 85% increase since 2019 in the FRB of our CFAR. And you'll see that dotted line there, which is the tier 1 threshold. So we're safely, at this point, within the required amount of funding for a CFAR. Now that 85% increase since 2019 doesn't really fully capture just the tremendous rise in funding that we've seen in Meharry's FRB over the same period of time. So that's been nearly a 9-fold increase since 2019 in AIDS focused grants at Meharry, which we are absolutely thrilled to see. And I think it's important when you look at this graph to realize that this is not 1 or 2 single awards. This is actually 12 different awards from 5 different institutes to a total of, I think it's 10 Meharry investigators. So this is a broad-based increase in research, and this is everything from R21 grants to R01 grants to a gamut of different NIH mechanisms. So this has really been a disproportionate increase in comparison to the total CFAR. And then finally, since 2017, our CFAR has doubled the number of NIH institutes that are represented in our FRB. You can see that going back as far as 2019, we were primarily our investigators primarily held grants from NIAID. Now, most recently, as 2022 and 2023, more than 50% are from other institutes. And you can see that at present, our investigators in our CFAR receive funding from 10 of the CFAR affiliated or CFAR supporting institutes. So now I want to cover some brief selected highlights of our CFAR before I conclude with a little more in-depth discussion of some of our major growth areas. So selected highlights, you've probably seen some of these pictures before and I've mentioned them, but in 2021, our CFAR was on one of only 2 new sites to join the CFAR network of integrated clinical systems. That was spearheaded by April Pettit and Tim Sterling. In 2022, Vanderbilt was very fortunate to recruit Dr. Kelly Dooley to lead the Adult Division of Infectious Diseases. And I think many people know that Kelly has been highly engaged for much of her career in HIV and TB clinical trials, including leading the ACTG TB TSG. She's also been a phenomenal mentor to just a broad range of investigators, supported by various training grants, including a K-24. So we are very excited to have her come to Vanderbilt. And in 2022 as well, Mukhtar Aliyu, who has been a longtime Vanderbilt faculty member with a longstanding engagement in HIV research, became director of the Vanderbilt Institute for Global Health, which is active in, I think, approximately 20 countries worldwide with a growing portfolio of grants and investigators. And one thing I should point out that's, I think, important for our CFAR is that both Dr. Dooley and Dr. Aliyu replaced prior division heads or global health directors who were not specifically HIV focused. And so this has really helped to invigorate those areas for us. In 2022, our CFAR was awarded an Implementation Science Hub, and this is a consultation program that's been led by Carolyn Audette and April Pettit as well. And it's one of only 8 of these Implementation Science Hubs nationwide. And this has been both a recognition of their expertise in the field of implementation science, but it's also led been a catalyst for our continued growth of investigators with expertise and interest in this area. And it's allowed us, I think, to really bolster this and ideally move to an implementation science core in the future. On the Meharry side, in 2022, Meharry received a very substantial award from the NIH Office of the Director to develop a cutting-edge lab facility that will greatly expand HIV research opportunities for investigators there. That was jointly led by Dr. Berthode, as well as assistance from Dr. Dash. And then we've had two investigators, both engaged in HIV science, who received an NIAID merit status to their R01. And NIAID only provides merit status to less than 15 R01s per year. And in the space of 2 years, both Dr. Brian Shepard and Dr. Kelly Dooley received these NIAID merit awards. So we're very excited about that. Additional highlights. So I showed the leadership chart of the CFAR previously, and I think it's important to understand that we have undergone a leadership restructuring that was in many ways a recognition of a number of the leaders that had been developed within the CFAR and their ability to take on more responsibility. And beginning in 2023, led by our executive committee, there was a deliberate an intentional process of succession planning to advance a number of the investigators who had previously been ESIs or early career within our CFAR, with a real, however, attention to diversity. And that is shown in this graph here, which beginning, if we look at 2020, women only held 1 of 12 CFAR leadership positions, and that was the same in 2015. In contrast, with these shifts, most of which have already occurred, but we have a few people still who will be formally joining shortly. But by 2025, women will hold 9 of the 21 CFAR leadership positions, or approximately 43%. And this will include 50% of core leadership positions or core director positions. And individuals from groups that are historically underrepresented in medicine will hold 6 of the 21 leadership positions. And this has been an improvement over time, but not as much as I think we would all like to see. So this is still an area of growth and improvement for us. And the importance of our CFAR has been recognized by the leadership both at Vanderbilt and Meharry. And we have seen a steady increase in institutional commitments and an additional substantial increase that'll be occurring next year. Importantly, as I mentioned, there's a burgeoning program in HIV research at the School of Nursing, and that's contributing as well. Additional selected highlights are our CFAR Diversity, Equity, and Inclusion pathway that's engaged over 20 trainees since it started. The multifaceted response to Tennessee's 2023 decision to decline CDC funds for HIV, which I'll mention in a moment, but much of which has been spearheaded by Tara McKay and April Pettit. And a new substance use focused K-12 faculty training grant from NIDA, one of the emphasis areas being individuals with HIV. And this is important because it will provide us with a pathway for new faculty now that our prior NHLBI HIV-focused K-12 has sunsetted. Other major developments that I'm sure many people on the call are aware of. The first was Meharry Medical College recently received a $175 million donation from Bloomberg Philanthropies, the largest gift in that institution's history, to help diversify the healthcare workforce and promote greater research and efforts to reduce health disparities. And then probably less well known is that Dr. Hildreth, the president and CEO of Meharry and our CFAR program co-director, was appointed by HHS Secretary Javier Becerra to the Scientific Management Review Board, which advises the U.S. government on the structure and operations of the NIH. So all of the changes that we've heard about with funding and also the importance of continuing to move forward HIV research priorities, we are very grateful that Dr. Hildreth will be in the room while these decisions are made. Additional highlights, Lauren Brown and Amna Osman received a $2 million PCORI grant for a study on advancing the science of engagement, trauma-informed research co-production to end the HIV epidemic. This was a milestone Meharry Cares collaboration, but it's also very important for us as well because it is a unique infrastructure, a unique research infrastructure of academic researchers paired with community members in a research dyad, and it will also be conducted at multiple sites around the Southeast. So congratulations. Lyle Cooper, pictured at the bottom, received a large award from Tennessee to capture service data for Tennessee syringe service programs, an area of that he is a national recognized leader in. And then recent grant awards, and was not possible to cover the dozens of NIH grants over the last few years, but just as a flavor, over the last 2 months, we've seen a R37 award to Kelly Dooley. Our group received another R01 award. We have a new Harold Amos Medical Faculty Development Award recipient in Celestine Wanjala, and Jessica Perkins, who's actually on the VU side, but a strong and engaged HIV researcher with the CFAR, received an early stage investigator award from the NIH Office of Disease Prevention. That was one of only 3 that were given out. So now I just wanted to close by talking about a few very specific initiatives that we've had recently. And this first one was led by external events, but I think many people on the call are probably aware that in 2023, the state of Tennessee decided to reject several $million in annual CDC funds provided for HIV prevention and surveillance. And those funds were provided to CDC-defined groups that increase risk of acquiring HIV, and that included MSM, transgender women, heterosexual Black women, and individuals who inject drugs. And this was really a seismic event that sent shockwaves throughout Tennessee, as well as throughout some of our community partners as well, who had to respond to this. And while the state replaced some of the funding with equivalent state dollars, they reprioritized this to lower risk populations, including pregnant people, first responders, and sex trafficking survivors. And CFAR really played a leadership role in mobilizing a prompt and vigorous research-based response. Research-based, I want to emphasize, involving Vanderbilt, Meharry, and CARES members, as well as engaging with other CFAR directors nationwide. So you can see in the background here, that is one of the mobile health units from CARES in this New York Times article detailing this. And this is several members of our CFAR research team who really led this very, very rapid response to a considerable disruption in our HIV funding landscape. And 2 of the things I'd like to highlight were an R61, now converted to an R33 application that was funded by NIMHD, which was led by April Pettit and Tara McKay, which is examining the impacts of these policy changes on the HIV continuum of care and service provision. And that's in partnership with TDH. And also collecting additional original data as well. It was initially funded as the pilot stage, but is now converted to the 5-year award. And many people on the call may have also seen this analysis, which was the cost effectiveness of preventing AIDS complications, or CPAC analysis of these funding changes. And this was primarily led by the Harvard CFAR. Many of the authors were from the Harvard CFAR, but also Aima Honkai and April Pettit from the Tennessee CFAR were closely engaged in this. And I think the key takeaway that I'll just summarize was that only 1% of the individuals who were prioritized by the new funding from the state actually made up the population of individuals living with HIV in Tennessee. And you can see there that it was estimated over the course of 10 years that these changes would lead to 166 additional HIV transmissions and 190 additional deaths. And I do want to emphasize this is something that's currently in flux. Some of those funds were rerouted through United Way back to these groups, but this is just an example of how quickly the CFAR can respond to these disruptions in key areas with a research-based response. And this also led now to the development, or was one of the main catalysts for our new CFAR Health Policy and HIV Scientific Working Group, headed by Tara McKay, who is at Vanderbilt and Vanderbilt University Medical Center, as well as Christian Amador, who's Assistant Vice President of Strategic Initiatives for the Meharry School of Global Health I mentioned earlier. And what this group will do is it will essentially catalyze collaborations and research between individuals working in health policy at Meharry and at Vanderbilt with members of our CFAR who may be more implementation science, epidemiology, clinical science focused. This will also then bring in individuals from community-based organizations, be it CARES or others, and ideally also bring in health policy investigators from other institutions as well. So we're very excited to see this launch. Another area that we've had major investments in is the HIV epidemic in Memphis and Shelby County. So Memphis is shown down there in the lower left, and while it's a 3-hour drive from Nashville, it's one of the geographic hotspots for HIV transmission in the United States. And as of 2024, Shelby County was experiencing a peak in a 6-year trend, and Memphis currently ranks, as I said, #2 in incidence among U.S. metropolitan areas. And of greatest major concern, 1 in 3 of new infections are occurring among youth aged 14 to 24. So we've established this that this is a major high priority. And our collaborations really began in earnest in 2016 in the area of PrEP adherence in collaboration with TDH, but they've really been supercharged, I would say, by a number of initiatives been led by Dr. April Pettit with Carolyn Audette, Lauren Brown, and others, supported by CFAR administrative supplements as well as other grants, and really aided by the engagement now of Latrice Pichon, who I mentioned earlier, who has just been an absolute world leader in the community-based participatory research field with a real focus on reducing racial disparities and improving the health of Black Americans, particularly those with HIV or those at risk. And so she, as I said, will be joining our executive committee going forward. I think I'm actually going to bypass the last slide and just get back to the seminar goals since I see we're almost at the top of the hour. So hopefully with that presentation, I was able to provide a history of our Tennessee CFAR, give you an overview of some of our current and future activities. And in the few minutes we have left, and perhaps we can go a little over if need be, it would be great to get feedback on how the audience thinks we've done to date, and then also areas where we could improve, and particularly areas for new cross-CFAR collaborations or partnerships.